Hello, my name is Dr. Rebecca Keith, and I am an associate professor at National Jewish Health. It is my great honor to present to you today our experience with long haul COVID. Most people with COVID-19 infection get better within weeks of developing their illness. However, some patients with long haul COVID develop a wide range of new, recurring, or ongoing symptoms that they experience for more than 4 weeks after their initial infection. And we consider those patients to have long haul COVID. Even patients with extremely mild or no initial symptoms related to their COVID have developed long haul symptoms that can last for more than 4 weeks. Long haul COVID is just one of the names that this syndrome goes by. This has also been called post-COVID syndrome, post-acute COVID syndrome, post-acute sequela of SARS-CoV infection, and long COVID. So if you're looking in the literature, you can find information about this syndrome under several different names. There is so much that we do not understand about long haul COVID. We don't understand the natural history of the disease or why people get this. We do not understand the underlying pathophysiology or the best treatments. Today, I'm going to update you on what we do understand so that we can begin to have a conversation about long haul COVID and the chronic sequela of an initial COVID infection. So common symptoms we see in long haul COVID include dyspnea and exertion and exercise intolerance. And this can be people who are elite athletes in the beginning before developing COVID. Weeks to months after their COVID infection can have ongoing shortness of breath and exercise intolerance, such that they're unable to even climb a flight of stairs or walk several blocks without shortness of breath. Many of our patients have ongoing fatigue or tiredness, even in the absence of sleep disordered breathing or other explanation. These symptoms of overwhelming fatigue and tiredness in some patients tend to get worse after heavy mental or physical exertion. So on some days, if a patient is feeling well and decides to do heavy exercise, like go for a run or something like that, they may have rebound fatigue for several days after that exercise or exertion. Many patients have ongoing cough or headaches. Some have ongoing chest or stomach pain. Some patients experience what we call brain fog or difficulty thinking or concentrating. This is particularly troublesome for many of our patients. I've personally had patients who are executives or high-functioning individuals who now can't perform their job duties because they have word-finding difficulties or difficulties with short-term or long-term memory. Many patients also have inappropriate tachycardia or palpitations with exercise. We can see this in our clinics, and patients often explain that they will be walking or doing minimum levels of activity, and all of a sudden they will feel their heart racing. We can see this when we do ambulatory oxygen assessments where we have patients walk for 6 minutes. Often their heart rate will start at a normal range, but then jump up to 120 to 140 beats per minute with just simple walking. Many patients have ongoing joint and muscle aches. Rarely do they have frank synovitis or inflammatory arthritis, but they'll have ongoing arthralgias and myalgias. Some patients have neuropathy, diarrhea, or sleep disturbances. In fact, we have seen worsening of underlying sleep apnea in the context of COVID. Some few additional symptoms include persistent fever or the development of rash. Some patients experience ongoing anxiety or mood disturbances after having their COVID infection. Many patients experiencing ongoing anxiety about their health or even some PTSD from being critically ill. Some of our patients, especially who lost a sense of taste or smell with their COVID, can have persistent loss of taste and smell. We've seen changes in menstrual cycles and hair loss. So Dr. Solomon focused on the pulmonary manifestations after COVID, and today I'm going to focus on the extrapulmonary manifestations of long haul COVID, specifically the neurologic complications and the dysautonomia. And again, most of our patients were in excellent health prior to developing SARS-CoV, and have long haul symptoms, even though they were in excellent health prior to developing COVID. Fortunately, these symptoms tend to improve over time, but we have seen patients with ongoing symptoms related to their COVID infection now 18 months after they initially developed infection. I personally have patients that I began treating after they developed COVID in March of 2020 that are still having difficulty with ongoing fatigue, exercise intolerance, or inappropriate tachycardia. So many different organ systems can be involved in long haul COVID. And this is depicted here from this figure from the BMJ, British Medical Journal, that outlines the different areas that can be impacted. Certainly in the heart, we've seen myocardial inflammation and ongoing tachycardia and palpitations. In the brain, we see cognitive dysfunction or brain fog, fatigue, sleep disturbances, and PTSD. We can see issues with ongoing diarrhea and gastroparesis. And in the lungs, we can see certainly ongoing shortness of breath and exercise intolerance. And so I think this photo kind of depicts all the different organs that can be involved and how this is really thought to be mediated by the ACE2 pathway that is present ubiquitously within our body. So let's start by talking about the acute neurologic complications of COVID. 36% of patients who have COVID infection tend to have some type of neurologic symptoms, and 25% can be due to direct CNS involvement with COVID. These can manifest as headaches, myalgias, loss of sense of taste or smell. Some patients have stroke or CNS vasculitis or encephalitis, Guillain-Barré syndrome, or encephalopathy and delirium. Here, this looks at the neurologic complications of long haul COVID. And again, this is thought to be mediated by the ACE2 receptor pathway. And certainly patients we have seen have easy fatigue. They have CNS involvement of their COVID with brain fog, dizziness, inability to concentrate, chronic cough. We can also see gastrointestinal symptoms, and altogether, this seems to be impacting our autonomic nervous system. Certainly, some people think that there's direct injury to the neurons from COVID, but other possibilities include indirect injury through inflammation or other means, or vasculopathy. And certainly, we are hoping that this is reversible, but again, I have seen patients that have had their COVID over 18 months ago and are still having symptoms such as brain fog and some autonomic insufficiency. Here again is a cohort of patients with long haul COVID, and this is 7 months of symptoms and what are the most commonly reported ongoing symptoms. Certainly fatigue, malaise, and brain fog top the list, but you can see other issues including memory impairment, muscle aches, palpitations, and shortness of breath. But I think this is a good synopsis of the things we are seeing and the prevalence in which we're seeing them in our long haul COVID patients. Let's talk about a little bit more about how COVID impacts the brain. So many of my patients are disturbed by cognitive changes or brain fog after developing COVID. And this can include deficits in attention, concentration, short-term memory, word finding, or cognitive processing. Again, these are patients that may have had high-functioning jobs in the past and now are unable to complete those jobs because of cognitive processing disorders or word finding difficulty. And this is likely multifactorial due to direct central nervous involvement, but also things like depression, anxiety, and fatigue can impact our cognitive processing. So at our institution, we have recommended a diagnostic evaluation with formal neurologic testing, in some cases brain MRI, to evaluate for evidence of underlying structural brain disorder. Some places are getting sampling CSF, and certainly a speech impairment evaluation to further identify patients with word finding difficulties. So what can we do about it? And honestly, the data we have about how to impact brain fog is fairly limited. We have had some success with cognitive behavioral therapy or interpersonal therapy, using speech therapy and cognitive linguistics. Some behavioral health and counseling with social workers or psychologists have been helpful. And some patients may not be able to return to work due to their ongoing deficits. Let's talk now about the loss of taste and smell. 44% of patients will have some kind of impact to their taste or smell. Many of those patients recover. 25% recover within 2 weeks and 80% recover within 2 months. This is good news because we can tell our patients who have lost their taste and smell that we're hopeful that this is going to get better over time. But unfortunately, some patients have ongoing symptoms 6 to 7 months after developing COVID. So what can we do about that? In some cases, we've used oral steroids to help with that. You can use alpha lipoic acid or omega-3 fatty acids. In some cases, we have had patients work with our ear, nose, and throat physicians on smell rehab, where we try to introduce smells and try to help them recover their sense of taste and smell. Let's now focus on dysautonomia. So this has been manifest as dizziness on standing or exertion, palpitations, or a POTS-like symptoms. Many of our patients with dysautonomia experience exercise intolerance and tachycardia upon mild exercise or standing. They can also have GI dysfunction and gastroparesis, sweating abnormalities, bowel or bladder changes, temperature dysregulation, and labile blood pressure. These symptoms are very similar to those experienced by patients who have myalgic encephalomyelitis and chronic fatigue syndrome. And this is a syndrome that's known to have to occur after viral illness. So it's thought to be a post-viral syndrome and has a strong association with autonomic impairment. So this is likely multifactorial and due to tissue injury. Again, the angiotensin converting enzyme 2 or ACE2 receptors are heavily expressed on endothelial cells, including those involved in the autonomic nervous system. So perhaps SARS-CoV is directly impacting these cells, causing tissue injury and injury to the autonomic nervous system. We can also see some of these symptoms in our patients who have been chronically ill and may have become deconditioned due to prolonged bed rest. We can see that perhaps this may be immune mediated when many pro-inflammatory cytokines cause indirect injury to our autonomic nervous system. And we have seen in some cases high titers of autoantibodies to G protein coupled receptors in those patients that have POTS. And even possibly some have postulated that mast cell activation syndrome resulting in cytokine storm and hyperinflammation may be related. But certainly that remains to be seen and further research is indicated. So what is POTS? POTS is postural tachycardia syndrome. And we define that as patients who have a sustained heart rate increase of greater than or equal to 30 beats per minute within 10 minutes of standing or a head up tilt table test. And our patients that I see in my clinic typically report that they have dizziness or lightheadedness upon standing or exertion. They develop palpitations, exercise intolerance, and rarely do I see GI dysfunction, sweating abnormalities, or bowel or bladder changes. So what can we do? And largely this is supportive therapy. We encourage our patients to drink lots of fluids to help maintain a higher intravascular volume. And generally, this is quite a lot of fluids, around 2 liters per day of water. We can use compression garments such as compression stockings or abdominal binders to help with venous return to the heart. We can ask our patients to increase their salt intake. And we have seen that slow return to exercise is also helpful. Mostly, I recommend my patients return to walking daily. We can also have them do a recumbent bicycle or isometric exercise Certainly, we want to make sure that we're keeping our exercise level low with only 50 to 70% of their maximum predicted heart rate. Because as we've talked about before, if patients over-exercise, they're often have symptoms like rebound fatigue, where they can have overwhelming fatigue for 2 to 3 days after heavy exertion. So we want to use the idea that low and slow exercise over a longer period of time helps rebuild our exercise tolerance. Some patients require medications to help support blood pressure, and we use fludrocortisone or midodrine to help with that. And finally, some patients with inappropriate tachycardia or inappropriate sinus tachycardia have benefited from low-dose metoprolol. So what about neuromuscular symptoms? Certainly patients have myalgias, and we can look for frank myositis with elevated CKs. We can check their thyroid. In some instances, we consider EMG. Many patients may benefit from gabapentin or pregabalin to help with some of those myalgias and neuropathy related to post-COVID. And it's important that we look for underlying causes of neuropathy, such as B12 deficiency, diabetes, and other etiologies, so that we can correct any underlying disorder. So in conclusion, this is just a brief overview of what we've seen in our clinics related to long-haul COVID. Many patients are developing chronic symptoms after COVID infection, and we call these patients to be impacted by long-haul COVID. And again, that's patients that have ongoing symptoms 4 weeks or more after their initial infection. This is a big global health problem. As the number of people infected with COVID-19 increases, we can expect the number of patients with long-term health consequences related to COVID to increase. And more research is required to better understand the pathophysiology of this disease and what we can offer to our patients with long-haul COVID. Again, thank you so much for your time. It's been an honor to discuss this with you today, and I'm looking forward to taking any of your questions.